So today I'm going to focus on high-flow nasal cannula, not a lot, because there is not much good evidence that high-flow nasal cannula makes a difference in terms of the primary mode of respiratory support, and then talk about nasal CPAP, NIPPV, and then non-invasive NAVA, and finally, nasal high-frequency ventilation is also used as a rescue mode, mostly, but not as a primary mode. And I have some disclosures, because most of you know, I am the inventor of the RAM nasal cannula, which I'll be talking about a little bit today. And then I also have a new ventilator that we are putting it through FDA for use in low and middle income countries. And as I said, if I get any honorarium, I donate to a charity. Okay, when we talk about non-invasive ventilation, there are 6 different modes that people talk about. So you have to be very, very careful when they say, what do you mean by non-invasive ventilation? The most common one, you're all familiar with, is nasal CPAP. You can do with bubble CPAP, or you can use a ventilator, or you can use an infant flow driver. All of them are the same. There is really no advantage of bubble CPAP versus ventilator CPAP. In randomized controlled trials, when they compared babies assigned to bubble CPAP versus ventilator CPAP, 20% of the babies failed both modes and got intubated. If you have a system in your NICU that you only use bubble CPAP, just stay with it. But if you have a ventilator and using CPAP, like I do in my hospital, we use ventilator CPAP. The reason we use CPAP with a ventilator is in case CPAP fails, we can always switch to NIPPV. That is the reason we don't use bubble CPAP. If the baby needs CPAP, we just put it on a ventilator. Infant flow driver, same. No difference between these 3 modes in terms of CPAP. Second mode is the Si-PAP. It basically mimics CPAP. It is just like CPAP because in the infant flow drivers generate the high pressure of about 10 to maximum you can get 15 centimeters. PEEP, we usually keep it at 5 or 6. So the delta pressure, PIP minus PEEP, is very little, somewhere between 3. For example, if you are 10/6, the delta pressure is 4, right? 12/6, the delta pressure is 6. If the really baby has high CO2 and has trouble ventilation, this is going to fail. And that's what the studies have shown. You have to use a high flow rate to get the high pressure and another flow meter to generate the low pressure. And you have to use a relatively long inspiratory time. They recommend as long as 1 second. So, and in studies, which I'll show you, comparing CPAP versus Si-PAP, failure rates are identical, exactly the same. So if the baby fails CPAP, he's very likely going to fail Si-PAP. So that is why third mode is the NIPPV, nasal intermittent positive pressure ventilation. And this one, it mimics invasive ventilation. It's exactly like intubated baby, except there is no endotracheal tube. We have a nasal prong, mask, or a cannula. So you are using a ventilator. That's the only trouble is if you really want to give NIPPV, you need a machine, a respirator. You can use any pressure you want. We usually start at 20/6. So the delta pressure is already 14 centimeters. 20 PIP, 6 PEEP, so 14. So the baby has problems with ventilation. You can easily improve ventilation and decrease the hypercarbia. The flow is controlled mostly by the machine, so you don't even have to set a flow rate. And shorter I time. We generally use 0.5 seconds as the inspiratory time on NIPPV. Next mode is the high-flow nasal cannula. The problem with high-flow nasal cannula, it's very easy to use, but it causes lots of injury to babies because the pressure is neither measured nor controlled by you. So depending on the size of the nostril, depending on the size of the cannula, you will deliver different pressure. Okay, so flow rate and the size of the baby, all of them will impact how much pressure gets delivered to the baby. And there's no way for you to measure the pressure when you're on high-flow nasal cannula. And that is why I'm reluctant to use high-flow nasal cannula is a primary mode of respiratory support in preterm babies with RDS. In pediatric ICU, in older patients, I think it's a very good way to support them. But in the NICU, in preterm babies with immature lungs, if you use higher pressure for a long time, you're going to cause more lung injury and more BPD. And I'll show you a study, largest study from Philadelphia. The newer modes are high-frequency, non-invasive high-frequency ventilation. That could be either using an oscillator, or in the US, we have a jet ventilator. And finally, another mode of NIV is the NIV-NAVA, neurally adjusted ventilatory assist, which I'll talk about at the end of my talk. Here is the largest study, okay, published in Journal of Pediatrics in 2014. Oh, sorry, this is not that study. This is talking about a randomized control trial in babies less than 32 weeks, 585 babies. Collins, Manley from Australia, Yoder from US. And these are the three largest studies that have been published today. This is the forest plot. You can see that looking at extubation failures, whether babies are on CPAP or on heated high-flow nasal cannula, absolutely no difference, okay? And BPD, no difference in BPD. Both babies on CPAP and heated high-flow nasal cannula had the same outcome and same failure rates. This is another large study that came from CHOP, Children's Hospital of Philadelphia. Out of about 400 NICUs in their system, they looked at the outcome of babies that were managed on CPAP or high-flow nasal cannula, or high-flow nasal cannula failed and they were rescued with CPAP. About 700 birth weight, about median birth weight, 780 grams, 780, gestational age about 27 weeks, and invasive mechanical ventilation at any time in their NICU was 85% of the babies failed and required CPAP intubation. Okay, length of stay, they stayed about almost 3 months. If you look at the outcomes on CPAP, this is about 941 babies, 333 babies on high-flow nasal cannula, 1,566 babies with high-flow plus or minus CPAP. So overall, about 2,500 babies from about 400 NICUs they looked at. This is what happened to these babies, okay? BPD or death, no difference. 50% of the babies had a diagnosis. 56% of the babies had a BPD or death, which is higher, statistically significantly higher in the high-flow nasal cannula group. BPD alone was also 10% higher, statistically significant. Number of days on the ventilator was 25 days versus 18 days in the CPAP group. Postnatal steroids for BPD use was also doubled, 12% versus 22%, 21% here, statistically significant. Discharge, days to room air also was higher. So babies were on oxygen, supplemental oxygen on high-flow nasal cannula much longer, 76 days versus 62 days in the CPAP group. And if you look at the IVH grade, no difference. PDA requiring treatment was also higher if the babies failed high-flow nasal cannula in the beginning. NEC luckily was not increased. ROP requiring laser treatment was also higher, 13% compared to 8.6 in the CPAP group only, or 10.8 in the high-flow nasal cannula successfully managed group. As you can see, compared to nasal CPAP, high-flow nasal cannula used in premature babies less than 1 kilo. All these babies were less than 1 kilo and less than 28 weeks. You can see outcomes are bad. It is convenient, but at the time of discharge, babies have lots of complications or morbidity. That is the reason we do not allow high-flow nasal cannula in premature babies as a primary mode of respiratory support in our NICUs. So and then following that, in 2016, Roberts et al. Called the HITS trial was published. These are in bigger babies. What happens in big babies? This is all more than 28-week gestation, equal to or greater than 28 weeks, 564 babies, multinational, randomized controlled trial, non-inferiority design, Australia and Norway, high-flow nasal cannula versus CPAP, no surfactant was given, birth weight is about 1,700 grams, mean gestational age 32 weeks. They're big babies. This trial was stopped early for data safety monitoring committee because a significant difference in primary outcome of failure within 72 hours of randomization. So babies that were randomized to high-flow nasal cannula, 25% of the babies failed and got intubated compared to 13% in the CPAP group. So they concluded in very low birth weight babies, when used for primary support of preterm babies with respiratory distress, high-flow nasal cannula resulted in a significantly higher rate of treatment failure than did CPAP. I think if you want to avoid failures, especially in the beginning, in the first 1 or 2 weeks, which is very crucial to avoid intubation and invasive mechanical ventilation, you should try to use only CPAP rather than high-flow nasal cannula. Once the baby is stable, coming off CPAP, and if you want to use high-flow nasal cannula, you may do that. But from the beginning, if you use high-flow nasal cannula, you, even in BLBW babies or ELBW babies, you're going to have more complications. Here is another study published from India, Mumbai and Hyderabad in 2018. Again, they did high-flow nasal cannula versus nasal CPAP for primary respiratory support from the beginning. Again, big babies, 28 weeks or greater. And here is the about very similar to HITSTA trial, little bit younger, 1,600 grams instead of 32 weeks. Here also they're almost 32 weeks. Antenatal steroids about 50 to 60%. And age at randomization within 30 minutes, 0.5 hours. So very early start of randomization to high-flow nasal cannula or nasal CPAP. You can see treatment failures within 72 hours requiring intubation was significantly higher, more than threefold, 26.3% versus 8%. And time to treatment failure, babies failed very early, within 3 hours compared to 22 hours. Especially in babies less than 32 weeks, the failure rate was even more. That is between 28 to 32 weeks, the failure was 38% compared to 10% CPAP. Again, the study was stopped after a planned interim analysis showing a significantly higher treatment failure with high-flow nasal cannula. How much did they use? They used 5 to 7 liters per minute of high-flow nasal cannula. CPAP group, they started at 5 centimeters of water. So that's the data on high-flow nasal cannula. What about CPAP? Now, we all use CPAP in the delivery room as the primary mode of support. And what does it do? What is the success rate? You can see in this 1, 2, 3, 4, 7 randomized controls and published from 2008 to 2013. Okay, early failure, that means babies got intubated within 5 days after starting CPAP in the delivery room. Look at the Colin Morley's COIN trial, CPAP or intubation trial. 59% of the babies that were started on nasal CPAP in the delivery room failed and got intubated. Rojas from South America, 43%. Suppor trial from the United States, 83% of the babies failed CPAP and got intubated. Again, these are the youngest babies, 26 weeks and about 800 grams mean birth weight. A CurePAP trial from Italy, 31% of the babies failed. Vermont-Oxford Network delivery room management trial published in 2011, 52%, nearly half the babies got intubated within first 5 days. Gopal from Germany, 33%. Canmas from Turkey, 42%. As you can see, 1/3 to more than 2/3 of the babies that were started on nasal CPAP in the delivery room failed and got intubated. You can say, well, the other half, 30 to 40% of the babies, we were able to manage only with nasal Si-PAP. That's true, but the failure rate is higher with younger gestational age, even in experienced hands throughout the world. This is the largest trial published by Kripalani et al. From Canada, and this is a multinational study, US and Canada, in the New England Journal in 2013. So unfortunately, they called this trial as this is the title of the paper, a trial comparing non-invasive ventilation strategies in preterm infants. It's really not a trial of NIPPV that people thought it was an NIPPV versus nasal Si-PAP trial. This is the largest randomized controlled trial. I call this a SIPAP, and I'll tell you why. 1,009 babies, all of them are less than 1 kilo birth weight, all of them are less than 30 weeks. Okay? Mean birth weight, 800 grams. Mean gestational age, 26 weeks. Look at the number of babies that failed Si-PAP or SIPAP. 60% of babies failed and got intubated. Now, how many babies are intubated before the randomization? 45% of the babies. Caffeine, 83% of the babies got caffeine. Look at the BPD rate, absolutely no difference. 33% or 31%. Death or BPD, again, no difference. Why do I say this is a SIPAP trial? Here is why. The NIPPV or babies that were randomized to NIPPV, 53% of the centers used a SIPAP machine. You cannot deliver NIPPV using a SIPAP machine. Okay, that's SIPAP. Settings, even with the ventilator or in the NIPPV group, they used a PIP of 9 or 10. So 10/5, 10/6. If you had a ventilator in your setting, in your NICU, and you were part of this trial, you were still not allowed to use more than 18 centimeters of PIP. And I told you before, NIPPV, most places, you start at 20/6, peak inspiratory pressure of 20. So this never even reached the minimum pressure we recommend when you're using NIPPV. So this is truly a SIPAP study. And rate 10 to 40. You cannot use rate of 10 and be successful. You have to start with a high rate whenever you are doing non-invasive ventilation, and then wean the baby to lower rates. Eye time, 0.3. That's not going to work. You should need at least 0.5 seconds if you're using non-invasive ventilation, either NIPPV or SIPAP. And no data was given on surfactant treatment. Another study in 3 years later from United Kingdom comparing Bi-PAP or SIPAP with nasal Si-PAP. Another randomized controlled trial, very similar to the Canadian trial. 540 babies, gestation less than 30 weeks, less than 2 weeks old. 8 NICUs participated in the trial. You can see about 870 grams. Number of babies under 28 weeks was 334. So a lot of babies were younger babies. Re-intubated within 48 hours, 20%. Whether you're on Bi-PAP or Si-PAP. Okay, that's why I tell you, if you have a baby on Si-PAP and he's failing Si-PAP, do not waste your time trying Bi-PAP or Si-PAP. Chances are the babies will fail. So you might as well either intubate or go to NIPPV. Re-intubate within 7 days, 34% versus 31%. BPD, with oxygen defined as oxygen at 36 post-menstrual age, 50% compared to 54%. Pretty high incidence of BPD in these babies, around 870 or 900 grams. So Bi-PAP, what did they do in the Bi-PAP? 8 PIP over PIP of 4. The delta pressure is only 4 centimeters. There is no way you can ventilate a baby that has trouble with high CO2. Eye time, they did use the long eye time. They started at a rate of 30. In the Si-PAP group, they started at 6. The primary outcome was failure of extubation within 48 hours. That's here. Okay, no different. They used infant flow advanced by care fusion. I know I've seen a lot of infant flow drivers in Romania and in Eastern European countries, but this is what happened in a randomized controlled trial. What about interfaces? This is another major problem. Why people don't like to use Si-PAP or NIPPV or Si-PAP is the problem with interface. How do you fix it? How do you minimize nasal septal injury and nasal deformities? Argyle prongs, Hudson prongs, nasal mask, sometimes we alternate, or Inca prongs. We developed this RAM nasal cannula. It's basically binasal prongs designed as a nasal cannula, and this gets attached to a ventilator or a CPAP, bubble CPAP, or conventional high-frequency ventilator. That's the only difference between RAM nasal cannula and the other prongs. Much easier to do. So why do we use RAM cannula? There are several advantages. We use that in the delivery room. We published this paper as well as a chapter last year. Here, babies that are on nasal cannula compared to babies being resuscitated with a bag and mask. When you use a bag and mask, the amount of tidal volume, when you're bagging it in, some of it goes into the nasopharynx, some of it goes into the oropharynx. Gas that is in the oropharynx is dead space. It doesn't take part in gas exchange. Whereas if you are using close the mouth and use the RAM cannula and deliver, all of them goes through the nasopharynx into the trachea. So there are no leaks, whereas mask, even in experienced hands, mask leak is very, very common. And if you follow the NRP guidelines, you need to use Mr. SOPA, whereas you don't have to do that. So simpler, no leak, you bypass the oropharynx, decrease the dead space, and much easier to use. That's the reason we use RAM cannula with TP's resuscitator or NeoPuff. Here is our experience that we published in the European Journal of Resuscitation in 2017. Yeah, all babies are less than 1,500 grams. We used NIPPV, it's a typo here, Si-PAP, this is using RAM cannula, and this is using mask that we used to do. About 800 grams, 27 weeks. Number of babies requiring intubation was significantly lower. 31% were intubated in the DR. Emergency intubation was also low, 29% versus 68%. Chest compressions was much less. And if you look at, even if the baby got intubated in the delivery room, by 24 hours, majority of the babies were extubated, 38% were still intubated compared to 66%. And duration of invasive ventilation was 2 days in the NIPPV group that we started in the delivery room compared to 11 days. Surfactant was given in both groups. 90% of the babies got surfactant treatment for RDS. So we also looked at our own experience. This is observation study, not a randomized controlled trial, in babies over 1,500 grams that we managed before with Si-PAP. Now we do NIPPV, about 780 babies, 770 babies. You can see intubation was 14% in bigger group compared to 7% if you give NIPPV. Chest compressions was no different. Air leaks, no different. Median duration of ventilation was only 1 day in the Si-PAP group compared to 1 day, but interquartile range 1 to 5, whereas 1 to 3. That's why it's statistically significant. But you can look at number of babies that required intubation in 24 hours, 17% versus only 7.6% in the NIPPV group. So both in small babies and in bigger babies, if you start NIPPV in the delivery room, I'm talking about babies that have respiratory distress, you're using a bag and mask or a T-piece, use your finger to deliver NIPPV, or in our case, we use the RAM cannula. But if you don't have it, you can use a mask to T-piece and start using your finger to give a rate of 40 or 60 per NRP and then move the baby. The reason why we have good success is after we move the baby to the NICU, we put the baby on NIPPV. So we don't try leave the baby on nasal CPAP because we know failure rate with CPAP early in the first week is much higher. So we put the baby on NIPPV and the baby is doing well, we quickly wean the baby to nasal CPAP to low flow nasal cannula. So this is what we do in the NICU. If you're using NIPPV, you make sure you keep the head end of the bed elevated 20 to 30 degrees so that the water condensing doesn't go into the baby's nostril and cause apnea or bradycardia. So the water will condense on the expiratory side, so baby doesn't get water coming into the nose. We again eliminate the dead space, allow space between the columella and the nasal cannula to avoid septal injury, minimize nasal trauma. If you're using for low flow cannula, usually the rate is over 2 liters per, high flow, 2 liters per minute, but we normally do not recommend using the RAM cannula for high flow as a high flow nasal cannula. But to be very careful. And there's a 15-minute adapter, so you can attach to any device you want. Bubble CPAP, ventilator, conventional, high frequency, NAVA, everything can be done. So that's what we do. The other question people always ask, how do you know if you are transmitting the pressure? Here is a study published by one of the neonatologists, Prabhu Iyer from Cleveland, and a respiratory practitioner. They took a test lung. This is a computerized test lung that's validated to do measurements. They created 30% leak at the interface and then used the 3 sizes, preemie, newborn, and infant. Cannula size, this is the nostril size, and this is the measured peak pressure. If we set 20 centimeters, you deliver about 70% of the PIP at the hypopharyngeal level. If you use the newborn size, you transmit 80%. If you do infant, you generate close to 80 to 90% PIP. So it's a rule of thumb. If I'm setting with a RAM cannula or any other interface, if I set 20 PIP, baby is not getting 20 PIP. Baby will get about 15 to 16 at the hypopharyngeal level. No one knows what the pressure is at the lung level because it's not easy to measure pleural pressures to get a good idea. So how do we do that? NIPPV. So we set a baseline pressure, usually 5 or 6. We use 6. Now the recent recommendations are start with PEEP of CPAP of 6. So we use 6. PIP, we start at 20. So 20 over 6. Rate, we start high rate at 40. Inspiratory time, 0.5 seconds. Why do we use longer inspiratory time? Because the time constant is prolonged with high resistance of the prongs or the cannula. Rate is 40. Flow rate, if you have to adjust a ventilator, your old ventilator, and you have to do it, we normally set it at 10 to 12 liters per minute. If the baby has BPD, he's on NIPPV, sometimes we have to use peak inspiratory pressure as high as 30 to 35 or 38 even. The highest we have used. PEEP, may have to use 10. So there are some NICUs in the US that have a separate BPD unit. What do? They basically have babies on 35 over 10 or 38 over 10. Remember, these pressures look very high, but because of the high resistance of the nasal interface, babies do not get that much pressure at the hypopharyngeal level. That is why you should not be afraid of using high pressure. You will not get into more pneumothorax. None of the trials have shown high incidence of pneumothorax with NIPPV compared to nasal CPAP. Here are the 10 randomized controlled trials that have been published. Okay, either as a primary mode or as at the following extubation from invasive ventilation from 1999 through 2016. You can see NIPPV failures on the green bar, CPAP failures are in the red bar. You can see in every single study, this is from my very first study from the US on NIPPV with nasal CPAP, 5% babies failed, got intubated compared to 37%. Keith Barrington from San Diego, Khalaf from Philadelphia, Kugeln from Israel, Moratti from Rome, Kishore from India, Lista from Milan, Menses from South America, again in 2012 from the United States, we did a multi-center trial, Ansel from Turkey. In every single study, babies that were managed on NIPPV, failure rate is 5 to 25% of the babies failed, got intubated, compared to 25 to or 29 to 73% of the failures in nasal CPAP. Clearly, much higher failure rate if you have a baby on CPAP compared to NIPPV. This is a systematic review and meta-analysis of CPAP versus either synchronized or non-synchronized. Because most places, we don't have a good way of synchronized NIPPV. Okay, all of us are in the United States, all centers are using non-synchronized, except if you're using NAVA, then that's the best synchronized NIV is the NIV-NAVA, but many centers don't have it yet. So if you look at the extubation failures in systematic review, synchronized or non-synchronized, it really doesn't make any difference. Failures were much less in this NIPPV group compared to CPAP group. In the mixed, neither NIPPV nor Si-PAP Krippalani's trial again showed no difference. Odds ratio, confidence interval crossed 1. There were no statistically significant difference between NIPPV and nasal CPAP in this study. But again, the authors rightly pointed out, Ferguson et al. From Melbourne, Australia, this is really not an NIPPV study. So I told you this is truly a Si-PAP study. Okay, there are a number of interventions we do to prevent extubation failures or improve rates of successful extubation. Here is again in this JAMA Pediatrics 2 years ago, CPAP versus head box, oxyhood. Again, CPAP is better than an oxyhood head box. Number needed to treat is 6. Very good. CPAP or high flow nasal cannula, no difference. Methylxanthines like caffeine or aminophylline, you can, if you use, you can prevent failures for every 4 babies, which is very good. Doxapram, not much difference. So very few people are using Doxapram in the US. It has a lot of side effects. NIPP versus nasal CPAP. If you randomize, manage babies on NIPPV compared to CPAP, for every 8 babies, you will have 1 extra failure in the CPAP group. Non-synchronized NIPPV or Bi-PAP versus CPAP, 8 babies. The best result is if you use synchronized NIPPV compared to nasal CPAP. For every 4 babies, you have 1 success with NIPPV, more success than CPAP. Okay, so they concluded that preterm infants should be extubated to non-invasive respiratory support. Caffeine should be used routinely, and they also mentioned NIPPV is superior to nasal CPAP in preterm babies. That is the reason I always recommend the NIPPV to minimize. There's another systematic review, Cochrane review, published in 2017 by Lemery et al. From Canada. They looked at 10 studies, nearly 1,000 babies. You can see this is their conclusion. If you start early NIPPV, so these are studies where NIPPV started right after birth, immediately after birth. Early NIPPV does appear to be superior to nasal CPAP alone for decreasing respiratory failure and the need for intubation and endotracheal tube ventilation among preterm infants with RDS. So clearly, the odds ratio is 0.65 or relative risk is 0.65. So confidence interval is less than 1. So combining all the studies, whether it is with surfactant or without surfactant before enrollment, or this is combined one. So from different parts of the world. And this is our study I showed you in 2012. This is Krippalani's study here in 2013. So putting all these 10 studies together, early NIPPV appears to be better. The other thing that is important is device. What device do you use to deliver NIPPV? Okay, respiratory failure by device versus synchronized or non-synchronized. Ventilator-generated NIPPV, the failure rates are much lower. Okay, number needed to benefit, 13 babies. If you use Bi-PAP or Si-PAP, called bi-level NIPPV, you will fail, no difference. Mixed devices, no difference. Non-synchronized NIPPV, you still have a significant reduction in extubation failures. So if we don't have synchronization, it is still non-synchronized NIPPV is better than CPAP. Non-synchronized NIPPV given with a ventilator is better than using a SIPAP or infant flow driver or Bi-PAP. Again, based on randomized controlled trials. Again, as I mentioned, this is how we start, 20/6, whether it's a big baby, small baby, it doesn't matter. We start here and then we adjust the pressures upwards or downwards. High rate, you should start. When the FiO2 is less than 0.4, PCO2 is less than 60 or 65, pH is okay, 7.25, then we start weaning the peak inspiratory pressure, and then finally the PEEP. Last one is the rate. When the baby, switch the baby from NIPPV, then the PIP on the NIPPV setting is 15, that is 10 over PEEP, 15/5, and the rate is 20. FiO2 is less than 0.3, we switch the baby to nasal CPAP. Off nasal CPAP, when the CPAP pressure is less than 5 to low flow cannula, we usually do less than 2 liters per minute. So we try to switch from one mode to the other, give at least 24 hours to make sure baby is doing okay. We keep the babies on room air, but on CPAP or even NIPPV, if the baby has more apnea, bradycardia desaturation, until about 32 to 34 weeks, actually, because if you keep the lung stretched, it promotes lung growth. So that's what they do in Columbia, in New York, where the lowest rate of BPD. There are many babies on CPAP in that NICU, but on room air, no supplemental oxygen. That's because stretch promotes lung growth. Again, weaning guidelines, wean PIP first, hold the rate, do not wean the rate until late, until the PIP is around 12 to 15 centimeters. Then you don't have to wean the rate to less than 20. 15 to 20 is fine. You can switch the baby to CPAP. We wean the PIP by 2 every 6 to 12 hours. Typically not more than 8 centimeters in a day. When the PIP is around 12 to 15, then we start weaning the rate by 2 to 4 every 6 to 12 hours. If baby does not tolerate weaning, we just go back to the previous settings and wait for another 24 hours or 12 hours. If babies are more than 34 weeks, bigger babies, then you can wean this much faster. So that's about CPAP, high flow nasal cannula, NIPPV. Now I'm going to talk about NAVA. Mostly I'm going to focus on NIV-NAVA. So as you all know, since you're using it, but it's basically conventional ventilator. Respiratory center sends a signal via the phrenic nerve, both left and right phrenic nerve, excite the diaphragm, diaphragm contracts, chest wall and lung expand, and there is change in airway pressure or flow or tidal volume, and that's flow triggered, ventilator delivers a breath. Here we turn it. As soon as the diaphragm gets excited or diaphragm is activated, the electrical activity of the diaphragm is picked up by the NAVA machine, they call neural trigger, and then the ventilator works. It doesn't matter what the flow is, what the volume is, what the leaks are. So that is why neural trigger, using the neural trigger, it may be the best way to synchronize in non-invasive NAVA. So what are the differences between conventional ventilation and NAVA ventilation? Patient controls using flow trigger in the conventional, right? Patient controls using neural trigger. So every respiratory effort is controlled by the respiratory center in the medulla. Initiation of breath is done by the baby. Rate, patient, for example, on pressure support mode, baby may control the rate. Whereas on NAVA, initiation of breath, how long the breath, inspiratory time, spontaneous breathing, rate of respiration, peak pressure, termination of breath, all of them are controlled by the baby. Machine just supports it. What are the controls we use on a condensed ventilator? You all know that. You set a peak pressure, you set a tidal volume here on a volume guarantee mode, you set an inspiratory time, you have to do termination of breath, you have to set a peak, you have to set a rate in case baby becomes apneic, FiO2. On the NAVA, the ventilator controls only the FiO2 and the peak. Everything is controlled by the baby. Synchrony, onset of initiation of breath, asynchronous, lot of times, we talked about it yesterday. Here, everything is good synchrony. Initiation of breath, size of the breath, whenever the baby wants to stop breathing, inspiration, he can do that, termination of breath. So, certain concepts you need to understand. NAVA level. What is NAVA level? NAVA level is basically equivalent to setting a PIP. So you choose a number 1 to 4 or 0.5 to 4. I'll show you in a minute. NAVA level that you set times the electrical activity of the diaphragm called EDI or EADI. You look at the peak electrical activity, the diaphragmatic contraction, minimum electrical activity after the diaphragm relaxes, and you peak minus minimum EDI, so delta EDI plus peak. That's a peak of 5, and then you add 2 centimeters more, you get a value. That is the peak inspiratory pressure. EDI is instantaneous integral of the diaphragmatic electrical activity expressed in microvolts. NAVA level, as I mentioned, is centimeters of water per microvolt. It's an arbitrary unit. It's a proportionality constant set by the clinician. Absence of a tidal volume increase with increasing NAVA level suggests that the Herring-Brewer reflex is operative, stopping the output from the respiratory control center at the same tidal volume level, whatever NAVA level you are setting. Let me make it a little bit more clear. So this is what the ventilator does. Okay, pressure delivered for NIV-NAVA. NAVA level is set, EDI signal is picked up, peak signal, this is the peak of EDI, this is the minimum EDI here, this is tonic activity of the diaphragm. Remember, diaphragm doesn't completely relax, then the lung will collapse. So there is certain activity of the electrical activity of the diaphragm is maintained, tonic activity, that is called EDI minimum. When the diaphragm contracts, that's the EDI maximum or peak. Okay, this is the EDI graph, this is the pressure over time graph. This is in seconds. So when EDI signal has fallen 70% of the peak value, the machine cycles into exhalation. Okay, so trigger level is set at point, so this is the trigger, EDI trigger. So the minimum trigger that in this baby, their measure was 0.3 microvolts. And you set 0.5. So when the electrical, the diaphragm drops below 0.8, the machine will give a breath, triggering. Okay, that's how you set it up. So as I mentioned, EDI minimum means tonic activity of the diaphragm. Then ventilator will be triggered at an absolute level of 0.8. So NIV-NAVA provides proportional assist in synchrony with the baby's own respiratory effort. Okay, so inspiration to expiration, cycling off happens because the machine is continuously monitoring the EDI, electrical activity of the diaphragm. This is the 100% of the value. When it drops to 70%, then it cycles into exhalation. So the inspiratory time and expiratory time, they're all dictated by the baby because it's based on how force is the diaphragm contracting. The only thing you are doing is you're helping the offload the workup breathing from the baby to the patient. Here's another example, NAVA trigger. So this is, then on this side is the biologic diaphragm, baby's diaphragm, no NAVA. And then you start increasing the NAVA level. So you wanted to move the workup breathing from the baby to the ventilator. let the ventilator do the work. So baby can use calories to gain weight, right? So as you increase the NAVA level, this is the NAVA level, they call this a break point. As you keep increasing, you start at NAVA level 1 and see what the PIP is and what the EDA peak is. Normally, EDA peak is range between 5 to 15 or 5 to 20, okay, on the machine. As you keep increasing the NAVA level, let's say you come to 2. Now, the delivered PIP or tidal volume doesn't change, and the EDA peak starts to drop. That's called the break point. Here, you don't increase the NAVA level anymore because it's not going to help the baby. In fact, during NIV-NAVA, if you have high NAVA level, 3 or 4, you increase the risk for abdominal distension and more gas going into the GI tract. So you really have to use lower NAVA level in babies who are on NIV-NAVA compared to babies who are intubated and on NAVA. So again, setup, placing the catheter, you're all familiar. They use the nose to ear to xiphoid or next distance. And this is available in, you have to have it on the bedside. If the baby is, there is 6 French 49 or 6 French 50 centimeter or 8 French 100 centimeters is there. You can use either nasally or you can put orally. So this is the formula you use. And when you're looking at the monitor, you want this biggest QRS complex should be on tracing 1. And these blue lines should be in tracing 2 and 3. And almost flat EKG, just the P wave, and very small QRS complex in the 4th trace. That means your NAVA catheter is in the ideal place. It's not too far in, it's not too far out. So here is the guideline, 6 French for 49 centimeter. Even 1 centimeter makes a difference because in these babies, the catheter may be in the stomach and the electrodes may be in the stomach, then you won't see any QRS complex. So dip the catheter in sterile water. Don't use anything else for a few minutes and then put it in nasogastric or orogastric insertion. Blue line is only, if the blue line is only in the top line, that means the catheter is too far in. If the blue line is here in the bottom, that means catheter is not deep enough. So you adjust and make sure when you pull the catheter up or down, the blue lines become channel 2 and channel 3. So normal EDA peak range is 5 to 15, which is continuously displayed here, peak. This is EDA peak. Normal EDA minimum is 2 to 4. Here showing 1.2, okay? So certain things, the people talk about. What is EDA peak? As I mentioned, EDA peak is equivalent to peak inspiratory pressure. This is the neural inspiratory effort or respiratory drive. If the baby is taking a big breath, the PIP will be, EDA peak will be high, 15 or closer to 15. EDA minimum, think of as PEEP. Spontaneous tonic activity of the diaphragm, preventing de-recruitment of the lung during exhalation. EDA trigger is like a flow trigger on a conventional ventilator. So this is the minimum increase in the EDA minimum to start a breath. Here is the EDA peak. 1 is this the neural inspiratory time and then neural expiratory time. Because you are not setting inspiratory time or expiratory time on NIV-NAVA. You are only setting inspiratory time for backup breaths, right? So this is spontaneous NIV-NAVA. This is how the baby decides the inspiratory time. Baby decides the expiratory time before the next breath starts. This is the EDA peak. This is the EDA minimum. This is beginning of EDI here for the next breath. This is all noise, background noise, okay? That's why you wanted to keep your EDA trigger around 0.5. If you do it 0.3, you're going to have a lot of auto triggering. The machine thinks the baby is taking a breath. Very sensitive. We already talked about break point, so I'm going to skip that. Generally, you start NAVA level at 1 centimeter of water. Observe the EDA peak and work up breathing. If the baby is struggling, you increase the EDI. If the ED is consistently more than 15 to 20, and the patient still has significant retractions, then you can adjust and increase the NAVA level in slow increments, 0.1 or 0.2 every few minutes. Adequate NAVA level will be when the peak pressure no longer increases, PIP, and the EDA peak starts to decrease. Then you can hold it there and then look at the gases, look at how the baby is breathing, and once it's stable, we can start weaning the NAVA level. That is like decreasing the PIP. Again, this is, I just showed you, talked about it. So here is a baby on Si-PAP of 5, and then they switch the baby to NIPPV, pressure control, 14/5, and the baby is still, this is the respiratory baby still tachypnic, and the peak inspiratory pressure is still hitting close to 40. So what they did, they increased the PIP limit to 40, and baby settled down. So babies take occasionally big breaths. So that is why when PIP limit is, they had initially started at 20 centimeters, and the baby was struggling to breathe. But you can check the upper limit of PIP to 30 or even 40. Baby's respiratory rates start to come down, and then blood gases improve. So set the NAVA level to get an EDA peak between 5 to 15. Higher NAVA level means ventilator is doing the work of breathing. I showed you in that picture, moving from patient to the ventilator. Trigger. So here is the EDA trigger here. This is the minimum tonic activity of the diaphragm in this example, 0.3, and you set at 0.5 trigger. So EDA minimum is 0.3. EDA trigger generally recommended is 0.5. Okay. Lower number of trigger means it is more sensitive, and as I mentioned, may result in auto trigger. So this is, I showed you this curve. This is the pressure curve. This is the PEEP of 5 or 6 centimeters. As the EDA peak increases, the diaphragm is contracting, baby is going to generate more PIP. This is your PIP, and then exhalation, and then back to PEEP. So these are the settings, suggested settings for NIV-NAVA. How do you start? I start with a NAVA level of 1. Maximum is 4. You adjust by 0.1 to 0.2 centimeters. If the PIP is low, baby is retracting, and EDI peak is less than 5, you want to shoot between 5 to 15, right? So minimum is 0.5 centimeters. In fact, if the baby is on 0.5 centimeters of NAVA, doing well, you can switch the baby to Si-PAP from NIV-NAVA. So EDA max should be between 5 to 15. If the EDA max is more than 20, increase the NAVA level. That means baby is really working hard. So you increase the NAVA level so that you can unload baby's diaphragm and make the ventilator to work. If the EDA max is less than 5, you should decrease the NAVA level. So NAVA levels in NIV-NAVA are usually lower than during invasive NAVA. Okay, so NAVA level is usually 0.5 to 1 during NIV-NAVA. PEEP, standard, 6 centimeters. You may increase it if the lung is not well recruited, 8 or 10, and minimum PEEP you want to keep around 5. EDA minimum. Normally it's around 2 to 4. If the EDA minimum is consistently above 1, you can increase the PEEP. That means the lung is not well recruited. If the EDA minimum is too low, less than 1, then decrease the PEEP. EDA trigger, as I said, 0.5. Rarely we have to go up to 2. In a big baby who's very active, keeps constantly triggering, you may go to 2. Adjust as needed. Backup pressure. This is in case baby totally becomes apneic, no respiratory drive, then you have to have backup pressure ventilation. It's a pressure controlled mode on the NAVA machine. So you set 15 PIP, 15/5. Maximum use 30 to 35. Rate, usually don't need more than 30. I time for the backup rate is 0.5 seconds. Trigger sensitivity, they have it as number 1 or 2. You start with 1 to see how the baby does. High pressure alarm, you set it at 40 centimeters. So you can have a standard order set like this and insert appropriate NAVA catheter, verify the position by looking at the EKG tracing. The blue lines are in the second and third channel. Put NAVA or NIV-NAVA. NAVA number, you start at 1. Usually you don't have to start at 2. I just put the range. PEEP of 6. Pressure support above PEEP is 6 for spontaneous breathing. Backup pressure control, PIP, 15 above PEEP. Rate 30, I time 0.5. Alarm for peak pressure, 30 or 40. If the baby keeps on triggering the alarm, just go to 40. Sometimes babies take a big breath, recruitment breath or sigh breath. Apnea time, you can set it at 2 seconds, which means rate of 30. If you set 5 seconds apnea time, the rate will be 12. So we normally recommend starting it at 2-second apnea time. Blood gases every 8 hours or PRN. Just a sample that Dr. Stein has given. So that's about NAVA. Last part in the last few minutes is nasal high frequency ventilation. So here is a study, a pilot randomized controlled trial published from Canada, Toronto, McMaster University. And they showed that nasal high frequency ventilation was not superior to biphasic CPAP or Si-PAP because they used very low pressures on nasal high frequency. They used 8 to 10. That's very low mean airway pressure. 37% failed on nasal high frequency, 65% of the babies failed in the Si-PAP group. It's a small study. Okay, BPD, pretty high, 80% versus 74%. That's the original pilot trial. After that, number of studies have been published, mainly observation studies, 6 studies, all of them include only 111 babies. And all of them, they showed, use nasal high frequency, you can improve ventilation, decrease PCO2, avoid reintubation, safe and feasible. These are the study findings. Here's another study from China in bigger babies, 28 to 34 weeks, primary nasal high frequency ventilation, and they showed that need for intubation was significantly lower at 24% compared to nasal CPAP. We just completed a trial. This paper is now submitted for publication. It's under review. I coordinated this trial in 18 centers in China, 300 babies. So we actually showed that in small babies, it was more beneficial. Bigger babies didn't make a difference. So these are the settings for high frequency. If you're using sensor medics or Bronchotron or Draeger or Leonie Plus or Stephanie or Sophie or Jet, you don't have to worry about it. In general, if you are using nasal high frequency, use the lower frequency like 6 or 8, not 10 or 12 or 15, 5 to 8. Draeger recommends 6 to 10. Jet, we use 4 hertz. Longer inspiratory time. That's the key thing. Low frequency, long I time. Instead of IE ratio 1 to 2, you may want to use 1 to 1. Here is what we recommend. Start at 6 to 8 hertz. May decrease to 4 hertz in babies with severe hypercapnia. And don't worry about the jet. You don't have the jet. Amplitude, mean babies on conventional ventilation, right? You look at the mean airway pressure on the conventional ventilator, multiply by 2, that will be your amplitude. Or you start at 20 or 30 centimeters. May increase to as high as 70 centimeters, we have used in some babies. Most babies, you don't have to use more than 40 or 50. If you use during weaning, set the amplitude equal to PIP before you extubate the baby from nasal high frequency to NIPPV. Start at 1 to 1, may change to 1 to 2 if there is evidence of gas trapping. Mean airway pressure, start with same mean airway pressure as on SIME or 2 to 3 centimeters higher than mean airway pressure CPAP. If the baby was on CPAP, failing, you want to do nasal high frequency, that is the mean airway pressure you want to set, around 8 to 10 centimeters. If you're using jet, you use an NIPPV as a backup rate, but you don't have the jet. So typically low hertz, long I time, IE ratio instead of 1 to 2, make it 1 to 1, and high amplitude. Those are the three things if you want to succeed on nasal high frequency. Again, it is used only as a rescue mode, very few data. Some COVID-related things, I showed you a little bit. Use a filter if you're using to ventilate babies, a viral filter between the ventilator circuit and the RAM cannula or the prong or mask. If you're using bubble CPAP, we put a filter, recommend a filter on the tubing that goes into the water column. If you're using, again, here is the setup where you put the filter on the water column. If you're bagging the baby, this is gas inlet, the pressure control here, or a disposable pressure manometer here. This is the babe mask. You put a filter here. Also, when the gas is coming out, you don't want it to go into the atmosphere. So connect it to the tubing outflow and filter so that no one gets aerosolization of the coronavirus. So you need two filters, one on the inspiratory side going to the baby, one gas coming out of the baby during exhalation or when you are allowing the baby to breathe. So these are some of the things people are recommending now if you are managing a baby that requires intubation or CPAP or resuscitation in the delivery room to minimize the risk of aerosolization. Thank you so much for your attention. We'll be happy to answer any questions.